Thank you, sir. I would be talking to you about phacoemulsification in a torn capsulorhexis. The incidence of a torn capsulorhexis is less than 1% in phacoemulsification surgery, and the subsequent completion of the surgery depends on the density of the lens, the size of the capsulorhexis, and most importantly, the experience of the surgeon. If you have an anterior capsular tear, there is always a possibility that during the steps of phacoemulsification, this can actually extend posteriorly and can get converted into a posterior capsular tear. So an errant capsulorhexis should always be prevented. Now, this is a case of white cataract which has been stained with the trypan blue dye. And in white cataracts, the intralentricular pressure is always very high, and there's always a chance of capsular extension. And just as the capsulorhexis was getting completed in this case, it extended towards the periphery, and with the capsulorhexis forceps, it further moved to the periphery. So a small amount of viscoelastic agent was instilled at the site of the errant rhexis, and with the capsulorhexis forceps, it was completed so that you achieve not a very circular rhexis but a complete rhexis. Sometimes you may do cataract surgery in cases of corneal opacification such as this, and it is important in such cases to start from an area where there is which is clear, preferably from the junction of the opacified area and the clear cornea, so that once you generate a flap with the help of the needle, you can actually see it, and then with the help of the capsulorhexis forceps, you can complete it. Now, when you come to the other edge of the corneal opacification, it is important that you visualize the edge of the rhexis. And because if you lose the edge of the rhexis underneath this opacified area, then it is almost impossible to find it. So at one go, don't leave it, just complete it, and you will have a circular rhexis. So underneath the opacity or underneath a corneal haze, don't leave the rhexis edge. This is what we studied, all the dyes which are available at that point in time: autologous RBC, fluorescein, trypan blue, indocyanine green, and Venetian violet, and we found trypan blue to be the best. Now, sometimes if you've not stained the edge of the rhexis before, you can still stain it later. Sometimes the needle, when you're doing a capsulorhexis, the needle disrupts the stromal fibers so that you lose the edge of the rhexis. So the staining can also be done post facto to locate the leading edge of the rhexis. Trypan blue dye can be used to actually visualize the edge, and then one can complete the rhexis in a normal manner. Because viscoelastic is there, so it stains a little differently, and with the help of the rhexis forceps, after actually seeing the edge of the flap, one can then complete the rhexis. At times, such as in this is a case of iridofundal coloboma with the anterior capsular fibrosis. This was unmasked when it was stained with the trypan blue dye, and then one can decide whether one still wants to do phacoemulsification or do extracapsular cataract surgery in these cases. When you're doing a rhexis and there's anterior capsular fibrosis present, then you may encompass the area of the fibrosis in the rhexis itself, so that subsequently the uneventful phacoemulsification can be done. At times, you may have to ignore the area of the fibrosis, such as in this case, where the staining was done with the help of the trypan blue dye. The fibrotic area stained a little more, but when the capsulorhexis was done, the iridocapsular complex was actually left untouched. Otherwise, you can cause traction there, and there could be zonular dialysis, or there could be a tear which may go to the periphery. When you do phacoemulsification, one has to be a little careful that you don't get that into your phaco probe. And after completing the phacoemulsification, implanting the lens, one can then cut the can separate the iridocapsular complex. Now, sometimes when you're chopping, this is the last piece which is being chopped. You may chop the rhexis itself with the chopper, and there is a nick which is there at the edge of the rhexis. which one realizes after the complete nuclear emulsification has taken place. And be very careful in putting the viscoelastic agent, because this can again go at the back. So too much of viscoelastic agent should not be injected. Only optimal amount should be injected. Now, this is a case where ripped rexes occurred onto the proximal side. Again, case of white cataract where the intralenticular pressure is more. The capsulorhexis was initiated. And just as one was completing the rexes, the capsulorhexis gave way. Now, at this point in time, ideally one should inject some amount of viscoelastic and then take out your instrument. But then this was cut with the help of the Vanna scissors. And gentle hydromaneuvers are then done, because now you have a keyhole rexes which can any time go at the back. And we advocate what is known as phacoemulsification in situ. That means as you chop these fragments, you emulsify them, you eat them or consume them immediately, so that the pressure inside the bag is decreased. And the rexes, there is no extra tension on the rexes to extend backwards. So you fragment them and you consume them at the same time. So the pressure inside the bag, this would decrease the pressure inside the bag and will make your subsequent steps much simpler. Now, viscoelastic is being injected as the phacoprobe is taken out, and again this is the last piece which is left. Again the same technique, phacoemulsification in situ. You just chop and at the same time consume the fragments. But too much of rotation on the proximal side is not advised because of the extension of the rexes which can occur, and we prefer to do bimanual irrigation aspiration in these cases, so that the cortical matter is aspirated away from the capsulorhexis margin, especially in the area where the keyhole was present. Do not inject too much amount of viscoelastic, and this is followed by a 3-piece intraocular lens which is being implanted. And again notice, because the bag, there's a keyhole rexis, so as the lens is being implanted, posterior capsular stria are seen, hence it is imperative at this point in time to inject some more viscoelastic to create some space for the IOL from the side port. And as you inject the viscoelastic, those stria, they disappear and the lens is placed in position. Now this is a case of a post-PK cataract where the rexis was done and it was circular and was central. But the nuclear emulsification that is being done is a little peripheral, and so with the chopper and with the phacoemulsification probe, the rexis has been ripped. And when you have that, then again the technique remains the same. That is, you do phacoemulsification in situ at that point in time, and at that position, consume the fragments simultaneously as you chop them. And this is followed by irrigation aspiration and placement of a single piece intraocular lens. And again, bimanual aspiration in these cases helps, because you can aspirate the cortical matter in a more controlled fashion when you use the bimanual method. Now, this is a classical case which has been shown many times, but a case which not everybody sees normally. And as soon as you give a nick, there is a rip which is there on both the sides. Now it is important to convert these linear tears into circular rexes. So small amount of viscoelastic is placed. Bolus of viscoelastic is placed at that position, and a nick is given in the distal part of the linear tear to convert it in a circular fashion. so that you have a discontinuous capsulorhexis, but still it is circular, and it is a challenge actually to give a nick in the proximal part, and this we have described with the help of two Sinskis. It can be given. Dr. Vasavara has described with the cystatome and with the Sinski. And again, this is this part of the tear is converted circularly, so that this linear tear again becomes circular. This is then done with the help of the capsulorhexis forceps. The subsequent steps would also depend upon whether the cataract is hard or whether it is soft. In this case, it was soft, so it was not much of a problem. But if it's such a situation, the cataract is hard and you have to move the fragments, then it becomes difficult because the rhexis has extended on both the sides. And again, a 3-piece lens is preferred in these cases because that will keep the capsular bag stretched and the movement should be very gentle. And you can have, when your capsulorhexis has extended, you can have you can have a nucleus drop, which occurred in both these cases. The capsulorhexis was extended at the proximal side, and when the hydromaneuvers are done, the hydromaneuvers were not very gentle, and as a result of which the nucleus drop occurs. Again, in this side, the rhexis extended here proximally, which was cut with the help of the Vanna scissors. But once you do nuclear emulsification, again, because of the torn edge of the rhexis which is present on this side, the nucleus drops. So what not to implant in a torn rhexis? Capsular tension ring and plate haptic design of the IOL should never be implanted. The caveats in cases of torn rhexis are that convert to SICS or to ECC if you are not confident of doing it. Salvage the rhexis. A gentle hydromaneuver should be done with gentle nuclear rotation. Phacoemulsification in situ should be encouraged. Bimanual irrigation aspiration is a better method of doing it, and careful intraocular lens implantation. Thank you for your attention.